and Autologus fibular reconstruction, a study of 09 cases.
Even though I am not ortho-oncologist, I have done few but many cases of such tumor cases successfully. My topic on respected chairman and dear friends, my topic on GCT distal radius. Chairman and dear friends, my topic on GCT distal radius treated by bloc excision, autologous fibular resection. I have nothing to declare. You know, distal third radius is the third most common site for GCT of long bones, and the site has further distinction of having more aggressive behavior of GCT with higher chances of recurrence and malignant transformation, with 1% is metastasized mostly to the lungs. It is site-specific treatment includes the curettage with bone grafting or cementing, but for aggressive lesion type 3 and 2 en bloc excision and reconstruction with non-vascular or vascularized fibular graft is the ideal treatment. The recurrence rate for primary treatment is relatively higher as compared to en bloc excision, making a later a more suitable and reliable option in cases showing aggressive lesions. Reconstruction after en bloc excision distal radius is a challenging task. Most patients are young, active adults demanding cosmetically acceptable and functionally stable adequate wrist. We have routinely used ipsilateral non-vascularized fibular autograft for reconstructing distal radius and present our experience with this procedure. Aims and objective: total 11 cases of GCT distal radius operated, en bloc dissection with non-vascularized fibular autograft, reconstruction of the distal radius at institute during a period from 2002 to 2017. We were able to follow up 9 cases and they are classified according to Campanacci Grade. Working up preoperatively, X-ray, MRI, chest X-ray, biopsy was done. The treatment was done, and we have evaluated these cases for functional and radiological outcomes and address the complication to determine the role of arthroplasty versus fusion according to the case. We all know reconstruction, planning and implant selection. After confirming the biopsy, measure the graft length by MRI, X-ray, add 0.5 to 1 centimeter for compression and adjustment. The fixation plan is by NCDCP. The fixation plan is by NCDCP, which are available now. But when we did these cases, most of the cases were by fusion if instability expected or if radiocarpal ligaments are extensively compromised. Take the slides, please. Not mine. Surgical technique: under GA, under tourniquet, proper approach, excising the biopsy scar, radical, extracorporeal, extraperiosteal excision en bloc, and tumor bed is treated if necessary with phenol and hydrogen peroxide. After proper hemostasis and ipsilateral fibula is harvested, fibular graft is placed at the site of the radius. Plate fixation was done with appropriate plate depending upon the arthroplasty is done or arthrodesis is done. K-wire stabilization is required if the lower joint is unstable and arthroplasty is required. Iliac crest grafting routinely at junction was done, and we routinely obtain 3 to 5 mm extra length of fibula to cover the compression of the radiofibular junction and error in taking the measurements. The post-operative protocol: plaster was given for 3 months, K-wire removal at 2 to 3 months. Gradual range of movement exercises was started. The intermittent plaster and intermittent mobilization is our protocol every 15 days, and full activity was achieved in 1 year. The mean follow-up was up to 2.3 year. Union at fibuloradial junction was at 33 weeks. Fusion was done. The union was earlier at 18 weeks. Grip strength recovered average 71% of the normal range of 62, and repeated X-rays were repeated to see for union, recurrence of the tumor and graft related complication. After first year follow-up was at 3 monthly intervals for 1 year and 6 monthly in 3 years. Thereafter patient was evaluated annually till the latest follow-up. Case number 1, expansor lesion lower end of the radius. This is the MRI picture. These are the excised tumor tissue, fibular graft harvested, and the plate put for the radiocarpal fusion along with the fixation of the radius bone. This was the result at 3 years, and after removal of implant, range of movement was almost full. This is another case where arthroplasty was done and the wrist was mobile. In in this case. This is the case 3. At the end, because of the addiction smoking, there was skin infection, plate was exposed, and after removal of the plate, the wound get cured. Case 4, distal radioulnar joint fixation was done by K-wire. This is another case where the total excision was done and the ulna was sterilized. 6th case, again the arthroplasty was preserved. The complication is subluxation in 3 cases, non-union in 2 cases, healed after grafting, superficial infection, 1 case cured after removal of implant, no graft fracture or resection, no deep infection, no local recurrence. Functional outcome in series of 9 patients, union rates, grip strength, empty, MSTS scores 91%, no tumor recurrence, osmosis acceptable in all patients, 4 were excellent, 3 good and 2 satisfactory. To conclude, if inadequately treated, being locally aggressive lesion with a known risk of recurrence, wide excision is preferred for grade 2-3 GCT of distal radius to eliminate recurrence risk. Non-vascularized fibular graft is reliable, technically simple, cost-effective reconstruction option. Radiocarpal fusion will be considered in cases with wrist instability or extensive ligament reconstruction, demonstrated superior stability and grip strength, and early union compared to arthroplasty in unstable wrist. En bloc excision provides reliable oncological clearance compared to arthroplasty in unstable wrist. En bloc excision provides reliable oncological clearance with excellent function, cosmetic outcome, recurrence rates are negligible, and complications are manageable. Autogenous iliac bone grafting enhances the union at fibuloradial junction. An accurate preoperative templating of the defect length is critical for proper grafting, sizing, and fixation. Regular postoperative imaging is essential. Functional outcome depend upon meticulous rehabilitation and protected mobilization. The technique ensures predictable union, acceptable grip strength, and durable long-term wrist stability. 3D technology, robotic technology will improve the results and reduce the recurrence. Live fibular graft is indicated in cases very large defects, poor local biology, previous failed graft, smoker or poor healing, or if the early union is essential and microvascular expertise is available. Thank you all for kind listening, and you are all welcome to